Hello, friends. I am Dr. Pankaj Anand, working as a senior consultant in critical care medicine and internal medicine at Fortis Hospital, Jaipur. Whenever we talk about monitoring the hemodynamics, we largely think and talk about how to monitor the macrodynamics, things like your cardiac output, your mean arterial pressure, your lactate. We hardly talk about what is actually happening at the microscopic level, the level where the gas exchange occurs, the level where the nutrients are exchanged. So it is very important that we actually learn how to assess the microcirculation and then direct our resuscitation strategies to aim and improve the circulation at the microscopic level. This is what I'm going to discuss in the next 10 to 15 minutes. Now, let me first discuss as to what is the microcirculatory system. We all know that it is the smallest element of the circulatory system, which is a dense network of arterioles, capillaries, and venules with diameters as low as 100 to 150 millimeters. The microcirculation is integral to the global functioning of the cardiovascular system, largely because the supply of nutrients and oxygen for aerobic metabolism, as well as the removal of the waste products at the cellular level, occurs via the microcirculation. Also, it is vital for maintenance of homeostasis because it is important for auto-regulation of blood flow as well as regulation of the uh, cutaneous temperature by the control of cutaneous flow. Now, if you look at the microcirculation, you have the arterioles, which lead to the meta-arterioles, which ultimately form the arterial capillaries. This is where the gas exchange and nutrient exchange occurs. They finally join back to form the venous capillaries, which ultimately drain into the venules, thereby completing the entire microcirculation. Now, what is it that controls the microcirculation? The control of microcirculation occurs at both levels, the systemic as well as local. Systemically, the microcirculation is controlled by the autonomic nervous system, by the renin-angiotensin system, and the vasopressin pathway, which is a neurohormonal mechanism, which basically determines the basal tone of the entire cardiovascular system, as well as also controls how much volume of the plasma that is circulating in the circulation. At the local level, the release of various neurohormones, chemicals directly from the endothelium, or the stimulation of the nitric oxide release or the vasodilator metabolites in response to the shear stress acting on the walls of the vessel is what controls the microcirculation. Now, if you were to talk specifically about what happens to the microcirculation in sepsis, this is a very important article published in the Physiological Review in 1960, where they actually studied the response of the microvasculature to an intravenous injected endotoxin in the guinea pig and the mouse mesentery. Around 5 to 15 minutes after having injected this, there were strong waves of contraction along the small arteries, arterioles, and the meta-arterioles. These ultimately caused an arrest in the flow and lasted for several minutes. There were then phases of dilatation followed by strong contraction, which at times went on. The phases of relaxation became more prominent. Ultimately, preagonally, there was a general and permanent vasodilatation leading to the death of the tissue. So in sepsis, the cornerstone of impaired homeostasis is a generalized inflammation of the microcirculation. The microcirculation gets clogged with microthrombi and there is extensive leaking. There is also endothelial damage. The smooth muscle cells lining the arterioles lose their adrenergic sensitivity as well as tone. The RBCs become more rigid, thereby increasing the viscosity of the blood, and there is also a destruction of the entire glycocalyx, which causes a lot of perfusion deficit in the microvasculature. So the endothelial damage manifests in largely three ways. First of all, the watertight junctions in the blood vessels actually get converted, become so porous that they become like sieves. So there is a leaking of large amount of proteins protein-rich fluid, ultimately leading to an extensive edema in the tissue, as well as an overall dehydration of the vessels. There is loss of regulatory function so that the nitric oxide system gets severely disturbed, and there is an activation of the coagulation cascade leading to the intravascular thrombosis with catastrophic manifestations. So the arterioles become hyporesponsive to vasoconstrictors as well as vasodilators despite increased levels of catecholamines. There is decrease in capillary density, and there is an increased heterogeneity of perfusion, largely because there is vasodilatation somewhere, vasoconstriction somewhere else. All of this causes the blood and oxygen to get shunted from the arterial to the venous compartment, leaving the microcirculation hypoxic, along with a decrease in the oxygen extraction. There is decreased oxygen delivery, tissue hypoxia, and organ dysfunction. So, my dear friends, why do we actually need to assess the microcirculation? As I said earlier, most of our resuscitation and monitoring strategies are focusing at restoring or monitoring the macrodynamics like the mean arterial pressure, cardiac output, your mixed venous saturation, etc. But the pathological shunting that is occurring at the microscopic level is many a times not manifested in the seismic hemodynamics and the various variables that are dependent on the oxygen derivation. So, and also the resuscitating the macrodynamics is not always associated with an improvement in the microdynamics, the organ function, or the survival of the patient. Now, improvement in the microcirculatory function, especially in sepsis, after an early resuscitation is usually associated with a reduced incidence of organ dysfunction, thereby highlighting the importance of the microcirculation. Secondly, if your microcirculatory dysfunction is persistent despite your resuscitation effort, usually this shows a worse outcome. Now, unfortunately, there is no single gold standard test to assess the microcirculation. It has traditionally been judged by the color, capillary refill, and temperature of the distal part of the body. Whatever the available methods are, they can be divided into the indirect, direct, and dynamic techniques. So if the peripheries are cold, if there is a delayed capillary refill time, if there is mottling of the skin, this usually indicates that the perfusion at the peripheral level is poor or there is significant failure of the circulatory system. Now, we all know that mottling is largely an irregular, patchy discoloration of the skin, which usually occurs because the blood flow becomes heterogeneous, and mottling has been actually assessed as a potential prognostic feature in sepsis. This is a very important paper published in the Intensive Care Medicine in 2015, where they showed that those with septic shock along with mottling had an almost 4 times increased chances of dying in the ICU. But the problem with mottling is that the assessment is almost subjective. So what I called mottling, you might not find it to be a mottling. So that is one issue. And secondly, in especially our Asian population, especially the Indian population with darker skin, it is many a times very difficult to assess the mottling. So the second thing we come to is the skin temperature. The microcirculatory function is important in the maintenance and regulation of body temperature. Microcirculatory dysfunction with loss of auto regulation can actually lead to core body temperature derangements during sepsis, and measurement of skin temperature may be a very useful means of non-invasively assessing the microcirculatory function. Now, coming to the various assessment tools that we have for microcirculation, you could be measuring elements of tissue oxygenation, which include the indirect methods like your transcutaneous tissue pressure of oxygen, your mixed venous saturation, your tissue carbon dioxide levels, which is usually measured with gastric tonometry or transcutaneous carbon dioxide, the lactate, or the NIRS or the near infrared spectroscopy, which I'll be discussing in detail. You could be measuring the perfusion at the microcirculatory level, which could be by the direct methods, which is the laser Doppler, the video microscopic techniques, the OPS, SDF, or the cytochem IDF, or the dynamic methods like the vascular occlusion test. Let me first talk about gastric tonometry. The basic principle for gastric tonometry is that if you are measuring the carbon dioxide levels within the gastric, largely within the stomach, it is a surrogate marker of the circulation of the gastric mucosa. So whenever there is hypoxia, the anaerobic metabolism leads to production of acid. We all know that. And this gets buffered by the bicarbonate ions, ultimately leading to an increase in carbon dioxide tension in the tissue. So if you are measuring the carbon dioxide tension, it was higher than the normal, then it means that there is more anaerobic metabolism. Now there are issues, optimal site is unclear. Largely the sublingual mucosa, that is underneath the tongue and skin, have been found to be useful. So sublingual capnometry has numerous advantages over the gastric tonometry. It is very easy to perform, obviously non-invasive, produces immediate results, can be used at the bedside, and it does not require pre-medication and acid suppression therapy. Coming to the next marker, this is the mixed venous oxygen saturation. This is slightly different from the central venous oxygen saturation, which we measure in the central lines. This is measured in the pulmonary artery catheter. It reflects the average oxygen saturation of all perfused microvascular beds. Now, in sepsis, microcirculatory shunting can actually cause a normal mixed venous oxygen saturation despite having severe local tissue dysoxia. Even though maintaining mixed venous saturation more than 65 has been advocated, and we were doing it a lot when I was doing my residency, but it has now been proven that it may not reflect restoration of local tissue oxygenation. And in the Surviving Sepsis Guidelines 2021, they have actually given up SpO2 as a resuscitation goal. Coming to lactate, we all use lactate in our resuscitation efforts. It shows a sharp rise in lactate concentration whenever there is oxygen, when oxygen consumption becomes limited by delivery. So it is a marker of anaerobic metabolism, largely a marker of poor perfusion of the tissues. So delivery of oxygen to tissues takes place via the microcirculation. Microcirculatory dysfunction can be inferred from hyperprolactinemia and occurs with tissue hypoxia. But this is where I would like to caution you. Lactate used as a specific measure of tissue hypoxia has its own problems. Why? You know, a high lactate could be because of excessive production of lactate, but it could also be because of a poor clearance. So if you have hepatic issues or renal issues, it might or might not reflect microcirculatory dysfunction. So just a single value of lactate is not definitely a marker of a microcirculatory dysfunction. Coming to more advanced techniques, the NIRS, near-infrared spectroscopy, it utilizes the attenuation of the non-visible wavelength of light by oxygenated and deoxygenated hemoglobin. Clinically utilized wavelengths between 700 and 850 nanometers. And unlike your pulse oximetry, NIRS uses the attenuation of both infrared and near-infrared light by oxygenated and deoxygenated hemoglobin. So it provides a non-invasive means of continuously assessing tissue oxygen saturation, what is termed as the SpO2. Now, a single spot SpO2 of less than 70% at presentation in the ER was associated with almost 3 times increase in ICU admission. So this was published in Journal of Critical Care. So it increases a low tissue oxygen saturation actually at presentation shows an increased risk of ICU admission, and it tends to identify critical patients who might not have been recognized just by seeing the vital signs. Another publication in the Emergency Medicine Journal 2012 showed that patients with severe sepsis or septic shock have abnormal muscle tissue oxygen saturation when they come to the emergency department, and an inability to normalize the tissue oxygen saturation in the ED after managing sepsis is usually associated with a much poorer outcome. Now, if you talk about the direct methods, they include the techniques involving highly sensitive video microscopes. It provides in vivo visualization of the microcirculation. It allows direct measurement of capillary density, perfusion, and flow dynamics. So whenever there is an abnormality of the microcirculation, which is detected by a video microscopy, it has been associated with an increase in an in-hospital mortality, especially in unselected ICU patients. So what you assess in video microscopic techniques is, we assess the microcirculation directly by the emitted polarized green light, which when absorbed produces an image which represents the RBCs as black bodies. And there are various techniques available. There is the orthogonal polarization spectral imaging and the side stream dark field imaging. This is how the circulation appears, the microcirculation appears on the video microscope. You can see the large vessels, the arterioles, the meta-arterioles, very well perfused. This is a normal picture. Usually done in the sublingual area, largely we know why, because they are easily accessible, non-invasive, and potentially reliable. The sublingual region is a good indicator for the indirect assessment of splanchnic microcirculation. Now, various types of video microscopes have been used. A third generation handheld microscope has recently been developed called the Cytocam IDF, which utilizes the incident dark field illumination. This is how it appears. Now, if you look at this photogram, this is, I think, the most interesting part of my presentation. You see the A picture, which is an early phase septic shock patient. You can appreciate the decrease in vessel density and the perfusion vessels, as well as of the perfused vessels, as well as an increase in the under perfused vessels. Can you see this? So this is a heterogeneous picture. Now compare it with a normal, healthy, this is largely your sublingual mucosa. You can see that the normal vessel density and proportion of perfused vessels can be observed. No heterogeneity is seen. So in sepsis, perfused vessel density, proportion of perfused vessels, microvascular flow index are all decreased, and your heterogeneity index is obviously increased. Coming finally to the dynamic methods of assessment, this is a vascular occlusion test. So what you do is, it obtains dynamic measure can be obtained after a brief period of arterial occlusion. A blood pressure cuff is inflated above the systolic pressure and slowly released. And then you plot the tissue oxygen saturation against time, allowing the derivation of the desaturation, resaturation, and the hyperemic slopes. And this is how it appears. Can you see? This is the desaturation, this is the resaturation, and this is the hyperemia duration. In a healthy subject, this is how the graph appears. But in a patient of septic shock, you'll appreciate that there is a decrease in the resaturation slope after a period of stagnant hypoxia, well with severity of sepsis and increased mortality. So the poorer the resaturation slope here, the more severe is sepsis and increased chances of death. So my dear friends, what are we taking home from here? Sepsis hits at various levels. It hits at the global hemodynamic level, where there is vasodilatation, relative hypovolemia, and myocardial dysfunction, leading to distributive shock. It hits at the microcirculation, where there is a reduction in the capillary density, increased heterogeneity of perfusion, leading to microcirculatory shunting. And it hits at the cellular or the tissue level, where there is hibernation of the mitochondria and the oxygen extraction deficit, leading to metabolic dysfunction. All of this affect and cause tissue hypoxia, ultimately leading to organ failure. So to summarize finally, microcirculatory derangement is common in patients with sepsis. It cannot necessarily be predicted from macrohemodynamic values. That's very important. An improvement in macrohemodynamic values in the critically ill patient does not always imply improvement in microcirculatory flow. Your patients whose microcirculation fails to improve following resuscitation are definitely at a much higher risk of mortality. A sublingual video microscopy is fast emerging as a gold standard for microcirculatory elevation to date, even though it's not very readily available in India as of yet. And finally, learning how to manipulate the microcirculation and whether this manipulation results in better outcome definitely needs a lot of research efforts, which are still going on. I hope this video has been of some importance and use to this, especially to the students. Thank you.